Hi, so the chapters that I'll be reviewing are chapters 8 and 16. Chapter 8 is discussing risk management in that all therapists face, especially how to assess for them and the legal implications that come with it. And the first risk factor that the textbook talks about is suicide, and it gives different statistics starting with 71% of responding psychotherapists report having a client who has attempted suicide at least once, and 28% have had a client who has had at least one client who's died of suicide. And Marcia Lineham, who's the founder of dialectical therapy, she has said suicide is a solution for the client and a problem for the therapist. So, along with statistics, it is the most prominent reason for death across all age groups. And women have more suicidal thoughts than men. However, men have attempted suicide more than women, or they die by suicide more frequently than women. And it is actually the seventh leading cause of death for men and the 14th leading cause of death for women. Men use firearms to commit suicide 50% of the time. And when looking at diverse backgrounds, people who have origins of two or more racial backgrounds are at highest risk of suicide as adults. And that's followed by American Indian, Alaska Natives, Native Hawaiians, and other Pacific Islanders. Suicide is the third leading cause of death for children 10 to 14 years of age, and it is the second most common reason for those who are 15 to 34 years old. And knowing risk factors when looking into if somebody is suicide risk is really important. It takes more than asking questions. So just knowing if there has been any previous suicide attempts, if there's the presence of any mental illness, any strong suicide ideation, hopelessness, distress and anxiety, evidence of impulsive or self-destructive actions, lethal methods or means, psychosocial stressors, personal losses and exposure to other suicides, childhood trauma, substance abuse, and if they identify with the LGBTQ community. Along with this, it's important for therapists to know the proper, guidances to how to assess for suicidal ideation. So that includes administering objective symptom measures, seeking out client records and historical information, recognizing the difference between chronic and acute suicidal ideation, and displaying awareness of different warning signs and risk factors. So, chronic suicide ideation is those who have attempted suicide many times, and each time they attempt suicide, the stress required to attempt suicide gets lower and lower. So, it requires less stress for them to attempt suicide each time. And then acute risk of suicide ideation are those who have attempted suicide at least once. And clients who have attempted suicide at least once are on the path for chronic suicidal ideation, according to this book. And when we're asking about when we're asking assessment questions, it's important to ask the plan someone has to kill themselves, and also what weapons they have in their home. And if we determine that immediate action is needed for the client's safety, we could include family, friends, and appropriate resources to help in removing any weapons from the client's possession. Along with that, we could also talk to their doctors and collaborate with them However, when it comes to that, it's important to keep the client's confidentiality always in mind. So if we are going to be sending any type of documents to the doctor, receiving any documents from the doctor, it's important to get consent from the client to do that, just because personal information is being shared. And it's also important to know that making no suicide or no self-harm contracts can be detrimental according to the textbook, just because they do provide a false sense of security to us, to the therapist. However, they do not have any actual power to prevent suicide, and if we do rely on that contract and a client does end up committing suicide, it does not have any power to hold up in court, because, like I said, it does not have any power to prevent suicide. So looking at other risks, there's also intimate partner violence. So when we're assessing for intimate partner violence, we need to use universal screenings, engage with each partner individually, and then use risk assessment measures to address concerns regarding intimate partner violence. One thing that they mentioned is how it's important to also distinguish the difference between intimate partner violence and intimate partner terrorism. When it's intimate partner violence, it is just physical violence, and in those cases they said it was okay to, not okay, but it would be safe to see the client together with their partner. However, if it is terrorism, then we should think twice before we do that, just because it did show an example of a couple that went and they saw a therapist together, and the therapist assigned the couple homework, and it was intimate partner terrorism, and the partner used psychological abuse to kind of use the homework as a way to tell the partner, you can't handle this type of stuff because you're stupid, you will never be able to do this. So terrorism includes more psychological and mental abuse than along with physical. You need to learn when assessing if there's risk, we need to know if there's any violence between the couple, the frequency of any physical aggression, any intended violence, the fear of intimidation that's present in the relationship, any pattern of coercion, and yeah. So I think I already went over basically the important parts. And also keep in mind duty to warn. If there's imminent harm, there's a potential for imminent harm, always report that. Another risk factor they mentioned is the risk of danger to the therapist. So in this case, it could be when it comes, what they mention mostly is stalking. So in most cases, clients can stalk due to rejection, they're seeking intimacy, they feel incompetent, they're resentful towards the therapist, and it could also be a predatory type of stalking. There's a lot more information on that. I feel like there was a lot of information in just one chapter. In just a chapter that had 14 pages, I definitely want to reread it, and especially when it comes to suicide risk assessment and intimate partner violence, working with couples, I know there's potential for both, and being new to the field, we still have so much to learn about the legal aspects behind therapy, because so far like we focus on strategies and working with clients, but now it's looking at the actual legality of it all.